Every time you take a breath, air takes a rapid journey from the open atmosphere down to your circulatory system. That journey relies on two completely distinct physical systems. The first is the macroscopic pump. This is the mechanical action of your chest cavity acting like a bellows, physically pulling bulk volumes of air in and pushing them back out. The second system is the microscopic interface, where oxygen and carbon dioxide swap places across a membrane. But a paradox can occur. The mechanical chest pumps flawlessly, moving normal air volumes, while the membrane grows thick and scarred. The patient suffocates despite taking deep breaths. To accurately diagnose respiratory failure, clinicians have to split the problem in half. They must decouple the mechanics of airflow from the chemistry of gas diffusion. They do this using pulmonary function tests. This is a standard mathematical toolkit designed to isolate and measure these two systems entirely independently. Surviving a breath requires both fluid mechanics and chemical diffusion to succeed. Pulmonary function tests provide the precise math to identify the exact point of failure. To test the macroscopic pump, doctors use spirometry. Two baseline metrics govern this test. First is forced vital capacity, or FVC. This is the total maximum volume of air a person can forcefully exhale. Second is forced expiratory volume, or FEV1, which measures the specific amount of that air expelled during the very first second. This chart compares exhalation volumes over time. Looking at the normal panel on the left, we see a steep downward curve. A healthy respiratory system clears approximately 80% of its total capacity in that first second. When the mechanical pump breaks down, it usually falls into one of two categories. The first is obstructive disease. The defining characteristic here is a physical difficulty getting air out of the lungs, typically due to conditions like emphysema or asthma. In panel B of this chart, you can see the mathematical signature of an obstruction. The curve becomes much shallower. Because airways are blocked, the volume exhaled in the first second drops drastically, resulting in a severely depressed ratio, down to 42. Looking at panel C, we see a mechanical paradox. The total volume drops because the lung is restricted, but the ratio of air exhaled in the first second remains normal, or jumps to 90%, simply because there is so little air to clear out. Returning to the flow volume curves, this restrictive pattern presents dynamically as a narrow, steep peak. The outward flow rate remains relatively high, but the lack of overall lung volume pinches the curve shut almost immediately. These curves definitively diagnose the mechanical pump. They measure exactly how much bulk air the chest can move, but they tell clinicians nothing about whether that air actually crossed over into the blood. Drawing bulk air into the trachea is only the first step. A significant portion of every breath never reaches the microscopic gas exchange zone. This slide details the concept of dead space. The anatomical dead space, which averages about 150 milliliters, represents the volume of the conducting respiratory passages that simply hold air without participating in gas exchange. Clinicians calculate the alveolar ventilation rate, or AVR, as breath frequency multiplied by tidal volume minus dead space. Because dead space is fixed, rapid, shallow breathing merely moves air back and forth inside it. Only slow, deep breathing significantly increases true alveolar ventilation. Once that fresh air clears the conducting passages and arrives at the alveoli, the mechanical phase ends. From this point forward, gas physics takes control. The movement of gases is governed by Dalton's and Henry's laws. Gases move down partial pressure gradients, and the amount of gas that dissolves into the liquid of the blood is determined by both that pressure and the specific gas's solubility. For example, carbon dioxide has a much lower pressure gradient pushing it out of the blood compared to the gradient pushing oxygen in. Yet, carbon dioxide diffuses just as efficiently because it is 20 times more soluble in plasma. This diagram maps the partial pressure gradients driving respiration. Looking at the alveoli section, you can see the specific pressures pushing oxygen out of the lungs and into the alveolar capillaries, while simultaneously driving carbon dioxide out of the blood. This slide displays Fick's law of diffusion, dictating how fast a gas transfers across the respiratory membrane. The diffusion rate is directly proportional to A, the tissue's total surface area, and inversely proportional to T, the thickness of that membrane. Because membrane area and thickness are the physical bottlenecks for survival, clinicians need a reliable way to measure these exact variables inside a living patient. Diffusing capacity, or DL, is the direct clinical application of Fick's law. To test the alveolar membrane's integrity, clinicians use carbon monoxide. Its extremely high binding affinity to hemoglobin creates virtually zero back pressure, pulling the gas cleanly across the barrier. This outlines the single-breath DLCO test. A patient takes a single inspiration of a dilute carbon monoxide mixture, holds it for exactly 10 seconds, and then exhales. An infrared detector then measures the expiratory concentration. By calculating exactly how much carbon monoxide vanished into the bloodstream during those 10 seconds, doctors can evaluate the physical state of the membrane. A low DLCO result indicates a loss of alveolar surface area or an increasingly thick barrier. The DLCO test allows doctors to look past the chest wall's mechanics, detecting membrane damage that is completely invisible to a standard volume test. To build a complete clinical profile, doctors map these two distinct physics systems against each other. By placing the macroscopic pump, our FEV1 to FVC ratio, on the y-axis, and the microscopic membrane, the DLCO score, on the x-axis, a diagnostic matrix takes shape. Take an asthma patient. Their data plots in the upper left. They show a poor FEV1 to FVC ratio due to airway obstruction, but their DLCO remains normal because the membrane itself is unharmed. Contrast this with a patient in the early stages of interstitial fibrosis. Their data plots in the bottom right. The mechanical pump and FEV1 ratio might appear perfectly healthy, but the DLCO score plummets. The membrane is thickening and scarring long before overall lung volume begins to drop. If a clinician stops at spirometry and misses the DLCO test, they risk entirely missing the silent destruction of the respiratory interface. Ultimately, human respiration relies entirely on the precise coordination of bulk fluid mechanics and microscopic chemical diffusion. Pulmonary function tests apply the fundamental laws of physics directly to the human body, giving clinicians the mathematical tools required to pinpoint exactly where that coordination is failing.